Functional anatomy. The main functions of the nose include respiration, humidification, filtration, temperature regulation, and protection. These functions are regulated specifically by the septum, turbinates, and nasal valves, external and internal. The nasal valves regulates the entry of air through the nose. They are the narrowest parts of the nasal airway and play a pivotal role in controlling the resistance to airflow. The nasal valve area is bounded by the caudal end of the septum, the returning portion of the upper lateral cartilage, the lateral nasal wall, the floor of the nose, and sometimes the head of the inferior turbinate. 3 dynamic valves can be classified. 1. Nostril/external. 2. Vestibular, and 3. Internal. External nasal valve. The external valve was defined by Sheen, 1978, expanded by Constantian, 1994, and codified by Rhi et al., 2010. It is located on the rim of the nostrils and is similar to a rectangular triangle with a lower base. It has 3 walls as follows: lateral crus of the lower lateral cartilage and fibroadiposal tissue of the nasal ale, medial, membranous septum and medial crus of the lower lateral cartilage, lower, nostril floor. Based on clinical experience and recent cadaver dissections, external valve collapse can be classified into either anatomical obstruction or anatomical instability. The 3 most common causes of anatomical obstruction in primary cases are caudal septal deviation, alar rim collapse, and nostril narrowing due to columellar widening. Vestibular nasal valve. The vestibular valve sits between 2 narrow apertures, the nostril and internal valves, with the most common obstructions being lateral alar collapse or vestibular webbing. The importance of the nasal vestibule and its role in respiration is described by Cottle, 1955, who states clearly that the vestibule is an effective series of resistor baffles that slows down the air currents and directs them upward for warming and moistening. Recently, Kakir, 2016, and Davis, 2015, have proven the concept of lateral crural tensioning as a means of flattening the junction of the lateral crus and accessory cartilage junction, opening the vestibular valve. Internal nasal valve. Mink, 1903, was the first to localize the internal valve to the slit-like passage between the caudal end of the upper lateral cartilage and the septum. The internal nasal valve is the angle formed by the junction of the nasal septum and the caudal margin of the upper lateral cartilage and is usually 10 degrees to 15 degrees. In primary patients, the most common causes of internal valve problems are septal deviation, turbinate hypertrophy, inward displacement of the ULC, and lateral wall collapse. Clinically, one should carefully examine the internal valve to determine the specific areas of obstruction, as they can often be multiple. The diagnosis can be ascertained by retracting the cheek outward, which should open up the internal valve. Positive Cottle test, leading to increased airflow, signals collapse of the nasal valves. Intranasal inspection before and after decongestant sprays is critical to determine the specific site of the obstruction. The Cottle test is performed by applying lateral traction on the medial cheek at the level of the internal valve. Subjective improvement of nasal airflow on the side tested may indicate nasal obstruction at the internal valve. Alternatively, a cotton-tipped applicator can be used to open the internal or external valve to evaluate for nasal obstruction at these sites. Narrowing of the internal valve angle is most frequently caused by either collapse of the ULC, bowing of the dorsal septum, or turbinate hypertrophy. In primary cases, partial collapse of the ULC is the most common cause and can be corrected with spreader grafts. Aesthetic anatomy and preoperative patient assessment. Attractive faces have certain proportions and relationships in common. To make an accurate diagnosis and establish the best treatment plan for a rhinoplasty patient, these proportions and relationships must be thoroughly analyzed. A natural horizontal facial plane is determined by drawing a line perpendicular to a plumb line superimposed over the head in repose and the eyes in straightforward gaze. This will serve as a future point of reference. The Frankfurt horizontal is a theoretical line drawn from the superior point of the external auditory canal to the inferior aspect of the infraorbital rim or the border of the lower eyelid cheek junction. The principle of dividing the face into horizontal thirds and vertical fifths is a useful method of evaluating facial features. Vertical fifths are divided using vertical parallel lines with each fifth equal to the width of an eye. The width of the nose should equal a vertical fifth. The face can be divided in thirds by horizontal lines drawn parallel to this line at the trachea, glabella, subnasal, and menton. The upper third is from the trachea to the glabella, the middle third from the glabella to the subnasal, and the lower third extends from the subnasal to the menton. A horizontal line through the labial-mental groove divides the distance from the stomian to the menton, lowest point of the chin, into a 1:2 ratio. The width of the mouth and the distance from the stomian to the menton are equal. Symmetry is determined by drawing a vertical line from the midglabellar area to the menton. Any nasal deviation from this line is likely to require septal surgery. The nasal bony base, red, should equal approximately 80% of the alar base width, blue. If the bony base is greater than 80% of the alar base width, osteotomies may be required. The nasal dorsum connects the radix to the lateral projections of the crura of the lower lateral cartilages by means of two diverging concave lines. These are the nasal dorsal aesthetic lines, brow-tip line, which are unbroken extensions of the superciliary ridges. The dorsal aesthetic lines originate on the supraorbital ridges and pass medially along the glabellar area to converge at the medial canthal ligaments. From there, they usually begin diverging at the keystone area and ultimately conclude at the tip-defining points. Wider, straighter, and less concave dorsal aesthetic lines for men. The tip is assessed to determine the supratip break, the tip-defining points, and the columellar lobular angle. These points serve as landmarks to draw two equilateral triangles with their bases opposed. The tip-defining points are composed of two equilateral triangles which extend from the supratip region to the apex of the domes to the columellar lobule angle. In the frontal view, bony dorsal width is ideally 75 to 80% of the alar base. Additionally, a cosmetic relationship exists between the height and perceived width of the dorsum. A lower height is routinely perceived as a wider nose, frequently seen in a saddle nose deformity or in certain ethnicities. To evaluate the proportions, the face is roughly divided into three equal horizontal planes. With regard to the nose, the intercanthal distance should be more or less equal to the width of the alar base, which is more or less equal to the width of the eyes. The nasal width is aesthetically about 70% of the nasal length. On the lateral view, the naso-facial analysis begins at the nasofrontal angle. This angle is formed by the intersection of a line drawn parallel to the infrabroglabella and a line drawn as a superior extension of the nasal dorsum that intersect at the nasion. The ideal angle varies by gender, with a more obtuse angle of 135 degrees acceptable in female patients versus 130 degrees in male patients. Perceived nasal length and tip projection can be altered by the position of the nasofrontal angle. A posteriorly and inferiorly positioned nasofrontal angle can make the nose appear shorter with increased tip projection, red. An anteriorly and superiorly positioned nasofrontal angle can make the nose appear longer with diminished tip projection, yellow. The normal ranges for the various nasofacial angles are: nasofrontal, A, 115-130. Nasofacial, B, 30-40. Nasomental, C, 120-132. Mentocervical, D, 80-95. The nasal tip angle is the angle of the nose from the tip of the nose to the base of the nose along the line of the columella and alar. The nasal tip angle determines whether a nose is perceived as upturned or downturned, and can lead to the appearance of either a celestial/snub nose or a hooked nasal appearance. The celestial nose is characterized by the lift at the curved tip, giving an elevated facial appearance. Also called upturned nose or snub nose, it is usually small, making the face appealing and attractive. A hawk nose resembles the Roman nose but typically features a narrower bridge and a more pointed tip. Hawk noses often have a curved shape, which can create a hooked appearance. Still on the lateral view, the size of any dorsal hump irregularity must be noted, in addition to whether it is strictly osseous, osteocartilaginous, or cartilage noose only. In the case of the lateral view, it is important to assess projection of the tip, tip rotation, tip columella lip complex, alar lobular complex, supratip break, columella double break.